Hi, I'm Dr. Christine Maguth Nezu, and this is Dr. Art Nezu.
Hello.
We have the honor of being asked by ABCT to answer a few questions about our background. We're going to ask each other those questions because we've been asked to do it together. So we'll start right now. First question was, what got us interested, or how did we become interested in clinical psychology to begin with? Well, why don't we start with you first, Art?
Okay, actually, I went to a special engineering high school because my initial interest when I thought about a career was in engineering and math. But I grew up in the 60s, and that was a tumultuous time having to do with civil rights, the Vietnam War, etc. And I became extremely interested in social justice issues. So when I went to undergraduate school at Stony Brook University, I initially wanted to become involved in social psychology. The more I became interested in psychology, the more I realized that it was clinical psychology was the field that I can best help people and fulfill my desire to be much more involved in social justice issues. How about you, Chris?
Well, I was an undergraduate theater and fine arts major, and I was studying directing, and I took my first psychology class. And at first I thought it would be really useful to take psychology to understand things like motivation and the human drama and human dynamics. But then I realized that what I was really interested in was a deep curiosity for what affects people's lives, the choices they make and how they live their lives, and kind of the trials and triumphs of everyday living. And so I decided to switch majors and make a huge career shift and go into clinical psychology instead.
Okay, thinking about clinical psychology and behavior therapy, who are the most important influences on our careers is the next question.
Well, this is probably my longest answer because I've had so many influences on my career. In my early graduate training days, my mentor, Dr. Michael Petranco, impacted me a great deal in terms of teaching me about basic learning theories, having an appreciation for underserved populations, and having a sense of advocacy for those populations. He also taught me the importance of clinical competencies and the idea of really understanding and connecting with people. My life partner over here, Dr. Art Nezu, has been my most trusted colleague for nearly 35 years, and so clearly he's had a huge influence on my career. He's given me honest feedback, we've collaborated together, and he's had both my personal and my professional back for all of that time. In terms of specific cognitive and behavioral work, I would have to say that many giants have influenced my work and my interest in clinical psychology. The early learning theorists, and then later people that really brought about a lot of information and research about human learning. So people like Don Meichenbaum, George Kelly, Fred Canfer, Michael Mahoney, Walter Mischel, Arnold Lazarus. There's been just so many. Alan Kasdan, Dave Barlow, all of these folks have greatly influenced my interest in clinical psychology, in cognitive and behavioral psychology, and finally all of my supervisors that taught me about how psychotherapy is a real journey between two people. They've influenced me a lot as well. What about you?
Okay, well, I won't go into as much detail as Chris did because I would say that many of those same individuals, in terms of professional interests and their academic contributions. But in terms of people that influenced my career, let me reciprocate to Chris that as my not only life partner, but substantial research and program development partner, she has influenced me greatly. And has humbled me at times as well. But I would also have to make sure that I say Tom DiZarilla, who was my mentor at Stony Brook, influenced me tremendously in terms of the interest in what we'll talk a little bit later about in problem solving, social problem solving as interventions.
Now I'm going to let you take the next one, Art, because it was a question that was related to your interest in specific cognitive behavioral treatments.
Okay, well, you can't go to Stony Brook in the 70s and not be influenced to adopt and better understand the cognitive and behavioral perspective. Some of the faculty there, for example, like Jerry Davis and Alan Ross, became later presidents of ABCT, initially ABT. And it was those kind of individuals that, along with the entire faculty, both in terms of the undergraduate and the graduate programs, that really kind of instilled a much more scientific approach to clinical phenomenon. And given my interests in engineering and mathematics, etc., from the beginning, that kind of coalesced very well. Okay, what's the next question? What are your most important contributions to research and practice in clinical psychology? Okay, here maybe we can start bragging.
Okay, why don't you start bragging first?
Okay, as I just mentioned, when I was a graduate student at Stony Brook, Tom DiZarella was my mentor, and he, along with Marv Goldfried, who was another major influence in my career, developed a conceptual model in problem solving. And at that point, it was talked about as social problem solving, to distinguish it from the kinds of problems that we all experience in daily living versus the kind of mathematical, logistical, intellectual, practical kinds of problems. And what that training program was to do was to help people adjust better to problems in living, to improve their well-being, etc. And one of the things that I've spent my entire career focused on, along with Chris, is developing programs based on problem-solving therapy for numerous different populations. Initially, depression, later on adults with mental retardation, later on with sex offenders, many populations that were experiencing medical problems along with depression, anxiety, and more recently with suicide prevention and reduction. So I would say that it's the development and the dissemination of that approach. The other thing that I'm very proud of is that I think I've served the field as an editor, having been an editor of the Journal of Consulting and Clinical Psychology, currently an associate editor of American Psychologist. I was the editor of the Behavior Therapist for ABCT, and numerous other journals as well. So I've had the pleasure and definitely the honor of helping to shape the literature and being one of the overseers. So hopefully I've contributed to the field in that way.
Well, I'll just add that in addition to the evolution of PST, which has been a real focus of my contributions in collaboration with Art, I view those as the most significant. However, I think another area for me has been the idea of really application or translation of theory and intervention from the laboratory into the clinical setting. And having had the opportunity to teach a number of core courses in our clinical Ph.D. program, I've had the opportunity to really disseminate the idea about competency in professional psychology. So in other words, it's one thing to develop the research and to conduct well-controlled studies and to have the evidence out there and the manuals to share and to disseminate. A whole other skill set has to do with competency and professional competency in implementing those kinds of procedures and effective psychotherapies. And so sometimes I think that gets a little lost, and I believe it's very important for people to focus on that kind of training as well. And so the work that I've done through the American Board of Professional Psychology, which is the gold standard for competency evaluation for psychologists, has been for me a very important contribution. And I think that coming from a behavioral background, the idea of each psychotherapist, beyond the book learning and the knowledge of the manuals, really having a behavioral demonstration and peer evaluation of one's competencies is an incredibly important part of our work. And I'd like to think I've made some contributions there as president of the American Board of Professional Psychology.
Well, I think you have, definitely. Okay, so what's the next question we're going to try to answer?
I think this is a good one for you. It has to do with how CBT can do a better job of disseminating, being disseminated to clinicians.
Okay. Well, having kind of been doing lots of training, developing treatment manuals, supervising, consulting with numbers of different individuals, more recently with the Department of Veterans Affairs and the Department of Defense clinicians there. It seems to me that there are really kind of two issues to focus on. One has to do with really trying to provide training that clinicians who are the frontline individuals see that is valuable. So the kinds of dimensions that might have to do with value, for example, is how effective a particular treatment is. And we all know that CBT or cognitive behavioral therapies are very effective. But how other kinds of issues, so how much of a burden is it to patients? How long does it take to learn these? As Chris mentioned before, competency issues. So how valuable can it be to the frontline individuals? Is it acceptable to patients? Is it difficult? For example, like biofeedback for certain kind of medical patients, along with stress management strategies, can be very effective. But do people have to go out and buy a large amount of biofeedback equipment? And that may again, impact on value, regardless of how effective it is. I think the second thing too is that CBT kinds of researchers really need to focus on the kinds of problems that clinicians particularly see in clinical and community settings. I think we do a great job at looking at DSM kind of diagnoses and say there's a particular kind of approach. So cognitive therapy, acceptance and commitment therapy, problem-solving therapy, et cetera, for depression or anxiety, et cetera. But the vast majority, as we all know, of patients or clients who come and see clinicians on the front line are not just going to be experiencing unipolar depression, and that's it. So there's going to be unipolar depression potentially, and some anxiety, relationship problems, maybe difficulties with their job, etc. And I think it's that whole package that we have to be concerned about. So how best can we provide the kind of services? And if people don't hear or see, clinicians don't see the value in what we can offer, then I think it's going to be a long tow before it becomes very widely accepted in all venues. Okay, I think Chris, why don't you take this next question?
Okay, this is one about the biggest challenges facing clinical science.
So what do you believe, Chris, are some of the biggest challenges regarding clinical science in the future?
Well, I think there's obviously a lot of opportunities as well, but if I'm going to talk about challenges, I think one of the things that I get concerned about is the idea that as people that are involved in advancing the clinical science, we sometimes get kind of caught up and fall victim to competitiveness or brand names of phenomena between different effective kind of psychotherapeutic approaches. And I'm concerned that that takes a focus away from the principles underlying change. And so I think that it's very important to focus back on those robust evidence-based theories that give us the principles of change or the principles behind what can be impacting the symptoms that someone is experiencing. And then to really take that theory-based understanding and to look at each individual in the context of their learning history, their development, their culture, and the plethora of factors that are going to impact how any one person, experiences some kind of disability or some kind of life challenge. And that we have to consider all of that in really looking at and matching the means of effective change for that person. In some ways, it would be an analogy that's similar to a pharmaceutical for someone who is experiencing some kinds of physical symptoms, and knowing that you have to take into account a lot of different pieces of information in order to make the right choice for for an individual based on all of those factors, other kinds of experiences they're having physically. In other words, knowing that there is no one size fits all for everyone.
Okay, I couldn't agree more. Okay, so the next question would be?
This one is to look at the recent findings about psychopathology and mental health that you think have had the largest impact on future research and practice.
Okay, so without giving away how old I am or how long ago I did my graduate training, one of the things that I clearly remember, just in terms of lay information or even in school, was the idea that once our brain was formed, it didn't necessarily change. And I think that over the past few decades, the term plasticity, brain plasticity, becomes extremely important. In other words, the brain continues to evolve and change, and it's often influenced by learning experiences. So that I think that neuroscience is one of those disciplines that have contributed, especially those areas that have to do with better understanding behavioral and mental disorders. So I think that that area has huge amount to offer us in terms of better understanding some of the underlying principles of why some of our interventions work and how they can work better.
Yeah, I agree. I think that the advances in brain science have really given us so much information and better understanding of the intricacies of emotion and cognition in the learning process and the ways in which our brains process that information. And I think that understanding that we have these different systems of learning and processing information contributes much to our understanding for psychotherapy. I also think that the other piece that's important is the evolutionary theoretical piece, and looking at those brain systems and the way we as humans process information as having a very adaptive evolutionary kind of purpose. And I also think it's a way to bridge many different approaches and theories. If we look back at Darwin and we look at both the psychoanalysts and the early learning theorists, both were fans of Darwin, so that evolutionary perspective and affective neuroscience may give us a real bridge to some of those theories.
Yeah, let's hope that it reaps what we hope it will. Okay, so I think this next question would be really, really good for you as someone who last year was given the award by ABCT for excellence in supervision.
Oh, thanks.
So
that was a real honor.
the question is, what changes would you like to see in graduate training and teaching in clinical psych?
Okay. Well, it's not surprising that I'd like to see, from what I've said, a greater emphasis on theories and the theories that support the evidence base for psychotherapy. And that includes the full spectrum of learning theories, as well as literature that supports affective neuroscience, theories of emotion, interpersonal approaches and theories to understanding human functioning, and contemporary psychodynamic approaches, as well as the literature that's out there on the significance of the therapeutic alliance. So I think that it's important to look at those theoretical based understandings. I also think that another thing I'd like to see emphasized in graduate training is the notion of cognitive and behavioral treatment being a very, very wide umbrella. And that rather than there being just one CBT kind of treatment, that actually it's an umbrella that could cover anywhere from 50 to 75 different behavioral and cognitive and combined and integrated kinds of approaches. And so I think that it's important to look at the emerging field, and that we've developed out of learning research, but that there is no one single CBT that really carries the name.
Okay, sounds good. Okay, I think the next question is for me.
Yeah, how do you see behavioral and cognitive treatments emerging or developing in the next years, or what do you think is going to happen in the future? What are some of the issues in the future?
Well, I think that the field of cognitive behavior therapies needs to kind of focus on a number of issues. I think we've talked about a number of them. You talked about, Chris, the need to really focus on theories. It seems to me that there's a difference between process and content. And one of the things that concerns me at times is the notion of there being too many cults, there being too many tribes, and then we tend to be very insular. And sometimes it's an idea of whose horse is going to win and which treatment seems to be the most effective. Coming from a Western society like the U.S., there's a huge emphasis on who's going to win the gold medal, and the silver medal and the bronze medal is good, but not necessarily as good. And I think that tends to stifle our creativity. I think that one of the fundamental understandings of what it is to be a scientist and a researcher is to be very open and not insular. So I think that what we really need to do is to focus on trying to better understand and underscore the notion that we have science that we should focus on, but also in terms of the patient. So it's a science that helps the patient, and that's basically why we're all here. I think in terms of content areas, it's things like mechanisms and action is kind of what I'm saying before, is a need to look within the cognitive behavior therapies and also outside, as Chris kind of mentioned before, to again, not to determine which is the best in terms of camps or tribes, or playing the Game of Thrones in terms of who gets to be on the throne, but again, what approach can best help patients. And the other thing too is not just in terms of focusing exclusively on individuals or groups or families, but looking at much more from a public health perspective. There is huge amount of area that I think that we could focus on in terms of looking at public health initiatives and issues and using cognitive and behavioral principles to influence that. I think, for example, just thinking about obesity or weight control, there are certain kinds of cognitive behavioral interventions that have been found to be effective, but not in terms of the long range. I think that how can we influence the media, how can we influence the culture becomes extremely important, and sometimes it's that very large public health perspective that becomes extremely important, and not just focus on the molecular, but looking at the molar as well. I think it's something that's probably mentioned by everybody, that we need to focus on diversity in terms of ethnicity, diversity in terms of sexual orientation, ages, comorbidity, etc. I think that there's a tendency for us to take a myopic point of view, but again, as the landscape of this country in terms of age, sexual orientation, and especially ethnicity is changing rapidly. What we really need to do is to develop programs that meet those challenges.
I think we're probably getting close to out of time.
Too much.
The last question that we have is really how membership has impacted our careers and
ABCT membership.
That's right,
okay.
Membership in ABCT. And I can answer that rather quickly to say that it's a small enough organization that there has been a start with a very small group of people, but then had a very, very sustained focus over time as it's grown, and that's really to advance learning-based treatments. And so it created for me a real forum for exchange of ideas, for people to be able to talk to each other, and to develop as a psychologist, to interact in the field, but then finally to be able to have access, because it was a small organization, to real luminaries in the field who were able to be questioned, to discuss things, and to have an influence.
Okay, so I'll end this interview by being brief. To paraphrase a very important political figure, it does take a village. And the success that I think both of us have is a function of the village that ABCT represents. So, thank you.
Thanks a lot.
Okay, take care.